Why are we here? Why are we here today? Why are we here this week? What is the national Nigeria-led conversation on the humanitarian development peace nexus? We're here because Nigeria matters. We're here because the northeast of Nigeria matters, but also the rest of the country, and that's why it's called a national conversation. We're here because about 9 months ago we conceived an idea that perhaps instead of looking at the negatives of what's going on in some parts of our country, we can look at the positives and also look at the positives from other parts and lessons to be learned from other parts of the country. We're here because we want to save lives. For me, when I took that Hippocratic oath, sort of 20 odd years ago, I keep telling people that I was forced into child labour at the age of 12. So you'll understand that makes me now about 37. But when I did that, sort of took that oath 20-something years ago, and actually before our current Minister of Health, who was my teacher at the time, we swore to uphold lives. We swore to save lives. That is what all of us, actually, whether you're a medical doctor or not, that is what our goal in life should be, is saving lives and upholding dignity. So this national humanitarian development peace nexus conversation, and this I will tempt you with, the first hot off the press. You'll be getting this brochure in a couple of days on the high-level day, which will tell you in great detail what has been done, what is being done, and what we're looking at to do in the future. But the week's program started yesterday with the most exciting event on youth and media, looking at the role of youth and media in conflict prevention. This room was packed full of 60+ young people from Borno, Adamawa, Yobe, Edo, Lagos, Delta. It was amazing. It was amazing to hear the lessons from those who've been in the South and in Delta, coming across and talking to their brothers and sisters from the Northeast. It was wonderful to hear the brothers and sisters from the Northeast sharing their lessons of what their experiences have taught them, and what documenting it through photography and through film has done for the healing process for them individually and also for their communities. It was wonderful to see the ideas spring forth from all of them, and the exchange of dialogue, really. Dialogue, the word dialogue means an exchange of ideas. That is the meaning of dialogue. So we had both a conversation and a dialogue yesterday. A conversation is more informal, we're chatting, I'm telling you about things. But in the middle of conversation, we also have dialogue, which is a more deep and meaningful exchange. And that was what we had yesterday. So we started on an incredibly high note. I went home not feeling tired, but thinking, yes, I can do this for the rest of the week. Today, as you know, we're here looking at humanitarian development nexus, early health system and recovery. This will bring together all of us here in this room to really discuss ways to achieve more effective collaboration between humanitarian and development programming and effective coordination mechanisms using SDG target for universal health coverage. Borno State, as I just said to His Excellency Michela, provides us an incredible example of just some amazing work that has been done, and I'm delighted that he's able to be here today. As I said to him earlier, it's an example not just of recovery from what was quite a severe situation a year and a bit ago, but also a model really to show for the whole nation of how to build back better. This afternoon we'll have From Food Assistance to Livelihoods and Self-Reliance. That event is being convened together with the Federal Ministry of Agriculture, WFP, FAO and IITA. They will look at current food security challenges and ongoing humanitarian development intervention by national, local institutions, CSO, private sector and international community. Their objective is to highlight opportunities for synergies and alliances that can enhance and accelerate sustainable solutions. On the 6th, in the afternoon, that's tomorrow, we'll have in the morning an NGO session, which we're not all invited to, I'm afraid. The NGOs have made their invitations. I know some of you have been invited, but they're expecting about 120 people. And this is when we begin to open up this room and spread into the other room. They'll have about 120 people looking at the challenges that NGOs and CSOs face in meeting that sort of humanitarian development challenge. And then in the afternoon, we have a private sector forum. Private sector investment is an enabler for the humanitarian development peace nexus and fostering an enabling environment for private sector involvement. Aid cannot do this for us in Nigeria. I killed the microphone. Aid cannot do this for us in Nigeria. We must stop the reliance on aid, and we must begin to focus on what we can do for ourselves. Why is it called a Nigeria-led conversation? Because it is exactly that. It is Nigeria-led. It's Nigeria-led because only Nigerians can solve the problems of Nigeria. Only we can find the solutions for our own problems. It is only when we work hand in hand with our international partners, taking the first step, taking the lead, that we will be able to deal with whatever it is that is in our way. Private sector is critical to this because from the young person who's selling water and has an investment capital of 10,000 to 100,000 naira to the multi-billionaire who has $2 billion to invest, all are important, and we need to foster, we need to push that very strongly. Humanitarian development, call it what may. If we have private sector involvement, we have private industry in this country that is thriving and that is engaged with the social development challenges that we have, then really Nigeria has no problems. And so we go to the high level. On the 6th in the afternoon, we invite you to join us at 7 p.m. for a little reception. We'll have a film, short series of films on educational initiatives in northern Nigeria, not specifically the northeast. And then we'll have a little reception just to sort of let our hair down a little before the grown-ups come into the room, and we have the high-level session on the 7th and the 8th. Those I will leave for later, but for now, I say thank you very much for being here and welcome.
With my own commissioner, the Commissioner for Health in Borno State. Please, can you take a greeting? I want to acknowledge all the distinguished personalities here. If I name everyone, it will be too long because it's just such an awesome list. But I must acknowledge my colleagues, directors from the Federal Ministry of Health who are here, chief executives of our agencies, my sister, Dr. Lakija. Please, can you take a bow? Please. Yes. This is a wonderful moment. And then, ladies and gentlemen, please, let's all be acknowledged. Thank you very much. It's a great pleasure to be here, and everything I'm going to say has already been said. So what I'm supposed to do is to welcome you. So I want to welcome those who came from outside of Abuja. Please feel welcome. And those who came from within Abuja. The Humanitarian Development and Peace Nexus has been a long journey for us here in Nigeria, and particularly in the health sector. Like my minister would say, Professor I.F. Adewale, say that every humanitarian emergency is important because of its impact on human life and development. If there was no impact on human life, it would not be as important as it is. And he gave example like if the Federal Secretariat crumbled and there was nobody in the building, it would just be another disaster that happened and we can deal with it and get on. But if it crumbled with all the people inside, it will be an international, a worldwide disaster. And so for us, humanitarian issues are critical because we are the ones in the health sector. We're the ones who have to deal with life. We're the ones who have to deal with the outcome of our intervention. Sometimes the outcomes are not as good as we would want. And so part of what we're doing today is to look at how we ensure that we have good outcomes, intended outcomes, expected outcomes, even in the midst of crisis. Like the Commissioner of Borno State will tell you, it's a tall order. Because while they are trying to save lives, your own life is endangered at every point in time. And I particularly commend the people of the Northeast, the Commissioner knows that, and Borno State in particular, because I say to people, while there was no airport functioning in Maiduguri, when everybody ran away and there was no access, the people stayed back with their people and they took care of them. And I want us to acknowledge that with a clap. You know, to keep them alive. when everything else seemed to have fallen apart. Honorable Commissioner, God bless you. And through you to the rest of your colleagues who stayed while there was no reason to stay. You could have run away, you are an elite, you could have gone anywhere in the world, but you choose to stay with your people. And so because of people like that, we had a chance to redeem ourselves. A few years down the road, after the crisis would have consumed our people if they didn't stay. We had a chance, and in the health sector, what did we do? We started to look at what can we do to have direct intervention in managing the humanitarian crisis. And so we tried to put together all the effort that had gone on. And part of what we did was to identify focal persons, identify responsible departments. But actually, the Department of Social Projects was actually created in order that we have a focused attention on humanitarian emergencies in Nigeria, with particular emphasis in the Northeast. Of course, as the dynamics are changing, also the dynamics of managing that is changing. And that's why we have other commissioners invited to this program who are not necessarily from the Northeast, because we realize that the dynamics of humanitarian emergencies is fast changing in Nigeria. And so we developed a strategic plan working with all the partners and the affected communities. It was that strategic plan that translated to the Buhari plan, the health component of the Buhari plan when this government came on board. Working with the states also, we developed the state-specific operational plans. But these are plans that deal with situations that give you time. We also had to develop emergency response plans, which we have been implementing, particularly in Borno State. We're about to start the third phase of that plan. And I believe that at some point the Honorable Commissioner will mention what has gone on. But I think that for emphasis, I want to say that in Borno State in particular, this Commissioner of Health, working with the Federal Ministry of Health, has a crop of human resources that have been trained and can manage to and can provide health service anywhere in the world where there is humanitarian emergency. So I think that a part of what we should do in the health sector is to harness that resource, build on it, have a management information system platform that identifies who these people are, what experience they have, and how they can be reached should they be required anywhere in the world. We also think that the Honorable Commissioner should be working with us to develop a package of training that we can use to train people around the world. So it's a tall order going forward. And so for this dialogue, for us in the health sector, is a great opportunity to not just showcase what we have done, but to harness the opportunities and the resources that we have among Nigerians. There are great resources among us, right from Jews to doctors, to nurses, to pharmacists, to nutritionists. We have people, to drivers, people who have given their life to the service of their fellow human beings. A lot of us work without insurance. That is what other people will not do, because it is our country. And so there's a great opportunity for us to tap into the resources that we have, build on it, so that in 5 years' time, we will not come back here to have this kind of dialogue. We will come back here in 5 years' time to say, thank God we have this dialogue. And because we have this dialogue, see how far we have come. So I want to thank and welcome all of you to this very important occasion. And I think that as the dialogue progresses, we will also be looking at how can we as a nation respond to the changing dynamics of humanitarian emergencies for the health sector. The Honorable Commissioner, I keep calling you, sorry sir, but you are my brother, what can I do? My colleagues from the Federal Ministry of Health and a few of you that were at the NCH in Umuahia in Abia State, will remember that the people from Benue State were up in arms against the Federal Ministry of Health because they felt that they had been abandoned. And so part of what we are doing is how can we have a framework, a strategic plan that identifies a threshold, so that once we get to that threshold, no matter where it is happening, the government must respond. The government is about saving lives. The Federal Ministry of Health is about implementing and ensuring that the government responds to the constitutional requirement that every life is precious and we're all entitled to a right to life, right? And so, whether you are in faraway Borno State or in Abuja, I don't know far from where anyway, depends on where you are, or you are in the comfort of the Hilton Hotel. I mean, we have seen riots going on in front of here. So you realize that nowhere is really as safe as we think we are. Or you are in Bakassi, in Cross River State. You should go there, live there with the assurance that if your life is threatened, should you, for instance, fall on bad times and become a humanitarian item, the government will find you and support you. The health sector will provide you good health, and your country will watch out for you. And so with that in mind, I want to, on behalf of the Honorable Minister of Health, Professor Adewale, who is on his way to Adamawa, the Vice President is unavoidably absent, I want to welcome all of you distinguished ladies and gentlemen to this very, very important dialogue. Thank you and God bless you. Good evening.
Thank you very much. Perhaps advocating very strongly that maybe there should be some framework, some kind of document in which, when and where we find ourselves in conflict or humanitarian crisis situations, it's not a question of thinking and dialoguing on what to do. You just activate the plan, and then government will find your way on. Thank you very much, Director. We will try and set the scene and progress from there. We will set the scene for today's conversation dialogue. We will invite Dr. Emurem or Dr. Okudo, if I need to, please come around and set the scene.
So, thank you very much. Basically, this is to sort of remind us a little bit of how things are, where we have organized health sector like in the Northeast. So this is essentially to go through what it is like out there, what the coordination mechanism is, and also to mention in a few words where there's already some level of humanitarian development nexus going on, and then my colleague from the Federal Ministry of Health will round up by looking at possible way forward and how we hope that things would turn out in the very near future. So essentially, to start would be to talk about the health sector needs and strategic objectives. Is that working now? So say that there are 5.4 million persons in the Northeast who are in need of health interventions based on, and this is based on the HRP. So there are also a number of interventions that are not clearly captured in here, but based on the humanitarian response plan, and that plan targets 5.1 million persons, and there are 11 to 15 partners within that framework. Outside of the framework, there are many more partners, but partners that are, so obviously this talks about, I think what we're going to look at later on, looking at coordination, how do we bring in all the partners that are playing out there, either as humanitarians or as development partners. And the three major objectives for the health sector is, because this is humanitarian, to provide life-saving and life-sustaining assistance. Coordination exists. There's, at the national level, a national intersector working group, and under that is a national health sector working group where the FMOH, the other partners at the national level, but also at the state level, there is a state health sector working group. In terms of legal frameworks, that's drawn from international humanitarian law or humanitarian principles, while for development, these are drawn from laws of the country. So essentially, that's basically wanted to talk about this a little bit, just because we know we might have a mixed crowd with us here today. So my colleague would come and talk about what's going on currently in the Northeast in terms of the areas where we're having already some good interaction between the two sets of players, and then look at how we can go forward from there. So thank you very much.
Where are we now? Presently in the Northeast, we are strengthening partnership with national and international development partners. We are trying to increase the size and capacity of health workers. We take Borno State as an example through the Health and Nutrition Emergency Response Project in Borno State. We have engaged 375 ad hoc staff to provide emergency care in 25 local governments in Borno State. We are rehabilitating and/or reinforcing damaged health facilities and infrastructure. We are strengthening the secondary health care and referral services along with recruitment and deployment of skilled and trained health workers. We are training human resource, and we are acquiring equipment for healthcare service delivery. Apart from training human resource, I would like to say that we need to increase the quota of health workers from the health institutions, and as well strengthen the health institutions in the area. Now, how are we going forward? We are going to develop flexible joint operational plan at the national and sub-national level. We are going to integrate, where possible, both humanitarian and development support in the operational plans. So we're going to be supported by a multi-year humanitarian response plan and a national health strategic plan that acknowledges and prioritizes areas and populations in those cities. We're going to create a one hazard plan and one hazard preparedness plan to encompass all hazards like the pastoralist and the farmers' crisis, to respond to them, disasters, floods, and whatnot. We're going to create a transition plan formulated and clarified in humanitarian development efforts. What are collective outcomes? Collective outcomes could be overarching, like universal health coverage, or specific to maternal mortality, neonatal mortality, and whatnot. Essential package for health services and health finances with social and financial protection. Preparedness for additional acute emergencies, that is risk management for all hazards, to including health security and IHR core capacities. Under governance and partnership, we're going to maintain health governance, in particular at sub-national level, district health management and community engagement. We're going to coordinate architecture that provides links between humanitarian and development partners. I'm going to create conflict-sensitive programs and give commitments to humanitarian principles. Thank you.
Without much ado, we will like to start the panel discussions. It's may I invite Dr. Okudo to please come help me. Come help me because we need microphones. There. Please, can you take me most respectfully invite the first panelists, and as we invite them, we would like them to take a seat at the other side of the room. It is my pleasure to invite Dr. Ngozi Azodo to the panel one. Dr. Oladejo of the Center for Disease Control. Dr. Shoaib of the National Primary Health Development Agency. Dr. Shoaib, is he here? Okay. We didn't clap enough, that's why he didn't stand up. Okay. You want to tell me you're representing him?
Yes.
Oh, okay, you're welcome as well. He gave you all the brief that you're required to give us. Okay. IRC. Please don't crucify me if I don't get it very correctly. Dr. Natugashe. Did I try?
You tried, but I'm not.
Please can't tell us the right pronunciation. Yeah.
It can be a mouthful, Natugasha, but I prefer to say McLean because that's identifiable with everyone who uses toothpaste, so we go with McLean.
Beautiful. Okay, it's McLean henceforth. And from the United Nations Fund for Population Activities, Dr. E. Can you, I am sorry, I don't want to murder that name, but is Dr. E here? Okay. Please don't tell him I couldn't pronounce his name. And from the Borno State's Primary Health Development Agency, Dr. Mele. Very much welcome. Okay, I'm going to migrate to the other side. Welcome. But our remit is simple. We're going to have some conversation relating to, as you have in that, I'm going to just read it. We're going to discuss humanitarian development nexus, providing health services while building back a better health system. In other words, this is like looking at a situation where you already have a humanitarian situation, and then we are providing services to build back an even better system. And I'm just going to throw the question and then move the microphone around. What synergies currently exist between humanitarian actors and development actors? So I'm going to give you like 10 seconds to think through, and we can start from you. What synergies currently exist? Are there linkages? I see in the presentations that there are plans to even forge greater synergies. But what synergies currently exist?
Yeah, thank you very much, the moderator. We need to really go back to the memory lane when the Federal Ministry of Health and the Nigeria Center for Disease Control actually moved into Northeast. The first thing we did that time was to have meetings with the State Ministry of Health and know exactly what was on ground. I still remember very well, Director Special Projects actually led that team, and I was part of the team. So initially when we came in, we realized that the agencies that were actually working, they are just working on their own. There was no really coordination per se. Although they used to have meetings, but they were not really well coordinated. And the Honorable Minister now charged Federal Ministry of Health through special projects as well as Nigeria Center for Disease Control to really move in. So we had meetings with the commissioners, with the Executive Director of Primary Care Development Agency, State Primary Care, as well as the state SEMA. During this period, we did a small study. Nigeria Center for Disease Control actually did a small study on what really was in existence at that time. And thanks to the Honorable Commissioner here present, who actually supported us. And we realized that all the agencies, I don't want to mention their names, they were just on their own. They don't know that they needed to come together and have one common goal. And the first thing we did that one was to have a plan. So we had a plan, we were there for 1 good month. Federal Ministry of Health sent us there. We were 25 in number. We were able to look at all the areas of the health sector. And that was the beginning of the Ministry of Health and all the national agencies going into Northeast. So we went to other states, but we concentrated more on Borno because that was where we really realized that there was a huge problem. So, but after this, we now started implementation and we realized that the agency, they don't really know what to do with surveillance. They are involved in treatment, they are involved in services, providing services, but they don't really know that they needed to really record those things they were doing. So we have to put it together. That's what they call IDSR in WHO and Federal Ministry of Health. That is Integrated Disease Surveillance and Response. So we had to bring it up in an architectural way to the extent that we had to retrain them, the health workers from the DSNO, the assistant DSNO, and even some of the state's health officials. So we now brought everybody together and we always have meetings regularly. So there's a lot of improvement now compared with how we started some few years back.
So some level of synergy. Okay.
Good morning all. Now, when the crisis started in the Northeast, we all know that a lot of partners were coming into the country so that they can assist in the Northeast. When it started, there was no coordination at all because they would just come. Sometimes they go to the National Planning Commission that they want to work in the Northeast, and they go. So there was no really a body that was really coordinating them. But realizing that there are so many women that are coming, the Federal Ministry of Health under Dr. Azoru's this ensured that there must be a coordination body. That we really know we need to know how many of them are coming into the country. What do they really want to offer at that level? Because a lot of them are coming, we don't really know exactly what they really want to do. So with the coordination of the specialties Department of Federal Ministry of Health, we're able to have get number of partners that are coming in, and then what are their goals and what are their motives at that. So for us in the MPHCDA, what we did was we tried to collaborate with the primary healthcare board in the state, so that because we want to ensure that services are still being provided, and then the human resource, we all know that in the Northeast over 800 facilities have been damaged because of these insurgencies, and about 21 general hospitals were also damaged. It involves human resources have been displaced, equipment have been damaged. So we really have to sieve, which areas are most affected, and then we try to collaborate with because MPC is primarily involved with primary healthcare system in the country, so we collaborated with the State Primary Healthcare Development Board to ensure that people who are really coming, because we want them to provide primary healthcare services. A lot of them, there are children, there are women who are pregnant, some of them are in the reproductive age, and also children who are malnourished and all that. All these services have to, so you have to sieve out each partner is coming, when they really find out what exactly they want to do, so we can challenge them. So with collaboration, with the same primary health care we all want, we're able to put a good coordination system that really coordinates the activities of these agencies. Initially when they started, the coordination was very well, but I want to assure you now, there's a lot of improvement in coordinations, and then we're really cooperating with the state primary health care board. Thank you.
Okay, just before, you mentioned partners, international development partners or other organizations coming through the Ministry of Planning, and they just find themselves in the conflict zone, right? And you talked about MPACDA collaborating or cooperating with them. These are like two levels of coordination, very high level, and then the operational level, which the earlier person spoke about. How else were you able to key in to say, or go beyond the state primary health care development agents in terms of these collaborations?
Yes, we used to have meeting with specialists in the Department of Prime Minister of Health. There is this, what's it called, presidential initiative on Northeast. It was led by Dr. Anas Salma Kolo, who was when she came back as a commissioner from Maiduguri, she was heading that unit. So there was this fora where we used to have meetings with partners, and NPS was inclusive. So we attend the meetings and then we coordinate the activities of...
Thank you very much. Please, Dr. Zoda.
Thank you very much. The question was, what relationship currently exists between humanitarian and development aspect, NEXUS? And there's a lot. First, when we had this acute humanitarian situation, the Ministry of Health, of course, the State Ministry of Health was already providing emergency services. The situation was bad because people had been dislocated, health system had been disrupted, and I don't want to say totally collapsed, but they were in a near state of collapse. What we did was to first support the State Ministry of Health, work with them to develop a plan, and then identify required resources in terms of financial resources, human resources, and other resources that will be required. And then, of course, look for the money. The money had to come from somewhere. And then we had people in the state. We have enough people in the state, actually. It's just that there were challenges because of where they were. They had been dislocated. So somebody had to make sure that those people were identified where they were and brought forward and put in a team so that they can provide relevant services in areas of need. And so the collaboration was strong. Nobody could have done that alone. Now, going forward, we realized that that was an emergency situation to respond to an ongoing crisis. So getting people back to their normal life, normal situation was part of, treatment, as it were. And so it was important to look at how the health system can also respond to that. And so we started working with the states to go through a transition period from an emergency humanitarian situation to a more supportive health system situation. Right now we're in a transition. So there's humanitarian services going on, and there's also the beginning of the restoration of the health system. We've had an assessment. We know what is where. Working with the states and with the WHO support, we've gone around the 6 states of the Northeast, and we have done a detailed assessment of the health system. So we know that there is a problem, but it's not as bad as it looks. We know what the facts are. We know there are deep challenges. We also identify the commitment of the states themselves, which is critical in trying to rebuild the system. And we remember from historical aspect that our health system in Nigeria, not just in the Northeast, is not what we would like it to be. So going forward, we are not planning to restore it to what it used to be. We are thinking that we should restore it to what we would desire it to be. And that's why we're talking about building back better. There's no need for us, if we had a building that was halfway collapsed, not painted, not furnished, the staff not trained, and then we aspire to go back to that place. No, that's not our plan. Our plan is that whatever it is we think as what we require as a health system for our people, that's where we are headed. And so it's important, therefore, that all hands are on deck. We strengthen coordination so that we avoid leakages and wastages. We are also able to identify the human resources where they are. We look at the 6 pillars of the health system and make sure that each of that pillar is appropriately addressed. And for us, governance is key to all of this. And so we must look at the capacity of the State Ministry of Health, to build back better, to sustain that process. And what is it that the State Ministry of Health needs to sustain that process? It's not about us here at the federal. Our roles are important and will continue to play that role. But in order for us to build back better, we must strengthen the people that are directly responsible, who stayed and will stay, even when the airports are closed.
And just, that's the executive chairman of the state. You probably, I don't know how much you collaborated with all these elements, the humanitarian development actors and all other partners in the state while this was going on. I'm sure it must have been quite hectic trying to coordinate, because you should be at the driver's seat, aren't you? Yes. Okay. But I'd like to hear from you, being on that driver's seat. What do you think should be the roles and responsibilities of these entities while this was going on? Humanitarian development and all other sub-state structures, governance structures, local governments, etc.
Dr. Azodu, because she's one of the most senior person that stepped into Borno when this crisis starts and then tried to put us back. And another great person also here is Dr. Lakija. We had a meeting once here in this venue about the nutrition, and she wanted to introduce herself, but I say, well, we do have some rudimentary coordination, but unfortunately what we have on ground are field officers that may not take decisions based on behalf of their organizations. So coordination is just operation at places of events, because at that time, this is the time of the influx of people from the security compromised area to the center into Maiduguri. At a time, you may think there are more displaced persons in Maiduguri than indigenous people. So people who are just placed in schools, in uncompleted buildings, uncompleted estates. So we have to be rushing, okay, what is the immediate need? We run to the partners providing water, we run to partners providing health services, and then try to coordinate all those things. And then most of the health facilities and public infrastructures were destroyed. So the few partners around UNICEF, WHO, we just do a quick fix of those facilities and provide any service that is possible for us. And at that time, we do have a wide gap of human resources. That was even before the insurgency. And with the coming of the insurgency, it had become worse because a lot of attrition, a lot of people don't even want to go back to those places because of the challenges they face in those areas. So we need to have human resource gap filled up. We started recruiting or engaging people on a very minimal pay or no pay at all to provide those integrated services in all those IDP camps. And sometimes people will just come in their hundreds, not knowing where to stay. They will stay under the first shed they find. So we need to have a way of taking services to those people. Now this is what developed into the now more formal IDP camp clinics in security compromised areas, and then also strengthening the overwhelmed existing health facilities in the safe areas. So with the coming of the Federal Ministry of Health and other partner decision makers, a proper coordination body was initiated. And then this is what is going on. We are having a fortnightly meeting with all the partners there, putting on the one plan that is put by the federal government, and then try to look at what is in the state plan to see how we are going to build back better. And also during the process of this rebuilding, we continue to provide these services and also improve on the quality of the services. So this is what has been going on now. Thank you very much.
Do you sometimes define roles and responsibilities for all these actors that are coming?
Yes, because every...
What sort of governance do you provide, in terms of this? So just take the two together.
So mostly it's through the coordination mechanism, which is led by the state and then co-chaired by the WHO IM. We said at the meeting, every partner put on decks, on table what you have. You come with nutrition intervention or providing health services, what is your scope? Then we have a mapping of this is what we have in the state, this is the challenge. So you go to this place and provide these services and then bring back a feedback. There may not be enforcement, but then this is something like a gentleman's agreement that this is what we agree and this is what you are committed to do. So you are going to take that up. So this is how the coordination is going on.
Thank you very much. I like that bit there. Maclean, I'd like to have you explore the definition of the roles and responsibilities for actors, including government now, in situations like this.
That I think really exist, and just first of all to acknowledge that we have a springboard, we have a foundation from the coordination structures that we have put in place, but I think taking it a step forward, what would be most fruitful and useful for the response would be having concrete documentation of roles and responsibilities of the different actors. I think we've also done a good job of harmonizing the different needs across the board and kind of coming up with a prioritization exercise, fixing those nuts and bolts of making sure that the actors are being held accountable to what they have committed to do and what we have jointly agreed to, as in respect to which actor, which partner is providing which level and quantity of resources. That level of accountability is very crucial for us to kind of see how resources can be equitably distributed and also lead to efforts of us not duplicating resources. The reason I'm talking about that is it's obvious that we'd all want to be very comfortable with areas that are easy for us to access, with areas that anyone can easily go in and out, and then with that we find ourselves with the temptation of every one of us kind of cramming in the same areas at the expense of the others that still need support. So opening up space and having that consistent political will of supporting not just the people that are in need, but also the people that are providing health services is very, very crucial. Speaking on behalf of the direct service providers in the field, I think we also need to look at how best we can support them, especially with psychosocial care. It's critical that I would think that getting someone as a humanitarian worker or a staffer of an agency, get them a job, they are paid, and they get their standard benefits is sufficient. But there are also those tangible psychosocial elements that are really very critical. We are working in a context that is very fragile, it's very sensitive. Staff and people are always listening to very horrific stories of what people have gone through, and then they end up with secondary trauma. So having putting in place mechanisms that would also provide some psychosocial support for the staff that are working in this context would really help their mental stability. So that's something, as we are transitioning and building systems, we also need to invest in the psychosocial care of our staff. At the root of all that is community engagement. How are we stipulating, as actors, how are we stipulating how we communicate with the people that we are serving? Is it a top-down process? Are we really organizing sessions. I mean, even having a dialogue like this, somewhere deep in Burma or somewhere deep in Goza, somewhere in Gujarat would be very helpful. Like having that ongoing, constant engagement and drawing out those needs as they come from the people would help us better shape our policies, better shape our practices, and also contribute to building a better health system. The reason we say that, because when someone feels that they are involved, they are part of the process, they own the process. If you're going to put a health facility somewhere and they've participated in that process, they will have a better responsibility in committing to making sure that the provisions are there because they were part of the process. So making sure that time to time our service delivery is really driven from down to up, and it's very visible, not just us as external humanitarian providers, but also as the government. That will take us away very far. Where are the women and girls? I wanted to clap more in as we are putting together our policies, as we constitute community coalitions and partnerships. Let's be intentional in how we are getting the women and girls, not just in numbers, but also making sure that their views are respectfully incorporated, their participation is intentionally being put on the forefront. That would help us have better representation and also enable us to have voices from these women and girls in what's working, what would work for them, and how they would like to see those. They would like to see systems that are being put in place and how they are facilitating their position. I could cap it on that note and keep advocating more for women and girls' participation and inclusiveness in these processes.
Okay. Things while trying to defining this, what should be the roles. You raised three of things that are more like challenges. In particular, apart from the fact that the chair had earlier on indicated that engagement or coordination is hampered by the fact that the officers that you see on ground are low authority, relatively low authority individuals who can't move policies further away from how it's fixed. But you raised the issue of psychosocial support to frontline providers, and that resonates with me because one of my best friends, is still suffering from this disease, working with IRC in Mubi. But he also indicated the fact that we needed stronger, more robust community engagement. You use the word communication, so that policies are better shaped. These are challenges, and I would like to come to Pharmacist Sheriff. Can I use that? Pharmacist Sheriff, who is actually involved in logistics in the conflict zones, and I would like you to perhaps push the frontier of challenges that you encounter in supporting Northeast efforts or conflict zone efforts.
Say that in issue of humanitarian crisis, a very important drastic action needs to be taken, and I appreciate the role played immediately by the Federal Ministry of Health. We had a teamwork. The issue was teamwork, very important, and the immediate response by the NCDC, emergency, the document they gave us was the basis of our formation as the project team. There was a team of about 25 different professionals that had meetings. Humanitarian crisis, you must have a good plan of action, so that you can deliver. And then you look at the affected areas of crisis, especially Borno. Are you going to go there and talk to them? No, they are not ready to listen. You must give them solutions, and they are ready. Wherever the solution comes from, they are ready to accept it. That is the challenge. So you must fix these solutions rightly and immediately. And that gave us to the issue of the Emergency Nutritional and Health Response Team by the Federal Ministry of Health. That was to look at in 6 months. How do you quickly? There were pictures all over saying that there was malnourishment, serious all over, that the children and the mothers were having serious issues of malnutrition. And that was a drastic movement. No matter what you are going to tell to the crisis, they want to eat, they need to eat food. So that was an issue too, and I know we addressed that issue. The issue of supply of foods was immediately addressed, and especially the domestication of the plan of action with the response of the states that were affected, especially Ministry of Health Barno. We had a communication, we were interacting to be able to see how do we quickly respond to urgent situations. And at the federal ministry level, with the supervision and the lead role of the special projects, when the committee sat together, the project team, thematic areas were brought out to address those thematic areas with individuals that can be responsible. For us, strategically, from the Department of Food and Drugs, when we talk of drugs, you know that the Department of Pharmacy has a role to play. And in this case of this emergency crisis, that brought to the bear that we have a store, the Oshodi Medical Pharmaceutical Stores, where we have drugs. What was the response immediately? Do we have any drugs that we can first take before we look at the issues of funds that will be released? You need to look at SUCO. So what we did, we were able to address, see if there are free drugs or any other health-related products in terms of mosquito-treated nets, in terms of disinfectants, because you know there will be disease outbreaks, there will be things like cholera. Luckily, we were able to, at first instance, we were able to console and we were able to get those drug items and health-related commodities supply immediately to the crisis area. And I think the Federal Minister of Health also raised about drugs worth almost 90 million immediately from stocks. So that was a stopgap. Do this before we can be able to go into the procurement of basically. And then it's not enough to say give the drugs, or it's not enough to say give the health-related committees. How do you deliver them, ensuring quality and safety and storage? These were factors and the challenges we faced. After sitting down, from the needs assessment by the team that went, we discovered that we need to get drugs for these people. And then that gave the idea and the innovation of coming up with the Nigerian Health Aid Kit. We had a health aid kit that addressed about basically 25 drug items, bearing in mind the common elements that were in the prone area, what we need to get, and how can we get these drugs immediately available. And I must appreciate the minister because we needed to look at our own local manufacturers. Nigeria has over 110 local manufacturers that are able to produce basic medicine that we need. So that set into motion after the release of funds to focus on getting these drugs and with the support of the state. Because how do we deliver these drugs? The manufacturers. Then we have to ensure that deliver to the store. The supplier must not deliver any of those products other than where it is needed. And where is it needed for us to start? Borno medical stores. What is the challenge with the stores? Are they favorable enough? Is there quality standard in the store? Can it take your drugs? Can it maintain this quality? That again was a challenge. But with the support, there were some partners who helped to modify, to upgrade the Borno stores, and then with the quick intervention of the joy in humanitarian crisis is when you see the state respond positively to you, welcomes you, and are ready to participate in this your intervention. Not thinking of where is the money we want, not the items. You can see service and wanting to accept these products. So I once again want to commend, I want to follow other people who have commended the Commissioner of Health, the quick response, immediately set into action. The medical stores was thrown open. We ensure that most of those products, the manufacturers must deliver them at the stores. And then cross-checking, ensuring quality, safety, pilferage. You can see all those challenges along the road before you are able to deliver these goods at the medical stores. That is not the journey. The stores is not the end. You need to deliver it to the community level. Okay. How are you going to do drug distribution? How are you going to distribute to over 25 local governments that we identified? And what medicines are you going to deliver? And who are you going to deliver those drugs to? At the community level or at the local government level? That was again a challenge. Again, there was a meeting in Borno to ensure that we have a team, the team that can provide services at the community level. The teams made up of a doctor, a pharmacist, a nurse, chewies, and all those tax safety activities. so that we don't have pilferage of those drugs. And then, who has the ability to take these drugs to those communities? Federal Ministry of again had to supply delivery vans of quality standards, so that these vans can take in those commodities and deliver them safely with the support of security. Security was a challenge. They were open to that. We needed security, you needed the pharmacist, you needed the doctor, you needed the driver. The driver was very important. The policeman was very important. These are all what I call a value chain, or what I call delivering services right from the source to the end. Because to ensure that crisis is delivered, it's not enough to hang on the middle of the road and say you have delivered services. No, if the impact is not felt by the community, you have not delivered any service at all. So these were challenges, and we appreciated that we were able to deliver those services. And the medicine, how often will you deliver the medicines and the commodities? We needed to do another mapping to look at how is it going to be a monthly or quarterly or based on requests. These were all issues. And accountability is strategic. How do you account for what you have delivered? How do you have the feedback mechanism? How do you know what drugs do you need to deliver? And there was a good cooperation. I learned in most local government areas, if the doctor is not around, the emergency nurse is there, the pharmacist, I'm bringing out the issue of teamwork. Everybody has his own significant role, and there was a delivery of quality services, and people were paid. Incentives, personnel, after the training, those personnel were given the incentives to be able to do their work. These are challenges. So a long humanitarian crisis, which is a continuous process, whether in the Northeast or all over the world, there must be an emergency response of qualified personnel with different fields of professional excellence to deliver services rightly, on timely, at the right place, at the right places. And again, the social aspect. The crisis phone, what do you talk to those mothers? We had a challenge visiting the IDP camps. You have to make sure that there are stores, there are food. And one of the challenges we observed was the quality of water. How are they going to drink this water? You want to give them medicines. The water is not clean. What are you causing? More diseases. So I remember our minister saying that the role of Ministry of Works, there has to be a collaboration to ensure that quality water is delivered, so that the mothers and the children can have quality water for environmental issues, cleanliness. So there are so many challenges, but whatever it is, as the third challenge, the ability for the personnel or emergency response makes the situation easy. I think we have learned both practically and theoretically. So Nigeria can say that in issue of managing humanitarian crisis, both in terms of personnel, in terms of resource delivery, and the funds, accountability of funds. We bought drugs almost close to 2 billion. You must account for those drugs, and you must account for the manufacturers. So these are challenges. But one challenge that the ability of those NGOs that were coming with drugs, they needed to be harmonization. Who is delivering who, and at what stage, so that we don't have replication of activities. What do you want to do? And I think the issue, the ministry and the state were able to address this issue, and we hope it should be done better. When there are interventions by NGOs, there's a need to sit down. What do you want to intervene? Where are you giving to us? What do we have? And I think it will make it a more robust. And I think that is the way forward, which I think is being addressed. Thank you very much.
Thank you very much.
They have been echoed, and it should be more robust. Perhaps it's one. Let me just. I will, in a minute, come to the audience and request or invite you to please ask questions that I have failed to ask, or seek clarifications to some of the answers that have been provided. So I will give, okay. Please, I will need an extra microphone. So at least 2.
The insurgency in Borno actually kicked off in late 2011, and then in full force by 2012. Now, the response that everybody is talking about is what started in 2017 early. The same convener of the dialogue we're having today raised an alarm, and the current president called a meeting in this same hotel where His Excellency, my governor, myself, the secretary to the government, the minister, head of UNICEF, head of WHO, and the, I think the humanitarian coordinator in the country. There was a very big discussion, and it was agreed that they should declare a state of emergency in Borno on health and nutrition. But before then, for over 4 years, we were grappling with the crisis. And my predecessor, that is the commissioner before I came in, Dr. Salma Kolo, was the commissioner in Borno State at the time when the actual crisis kicked in. The last speaker was talking about doing something in 25 local governments. Around that 2012, you could not go beyond 7 local governments. About 20 of the local governments were out of reach, and that was when we really had the crisis. We were overwhelmed. The government at the federal level did not have sympathy for us, and we were struggling, and we were still trying to maintain services. And believe me, all the different health sector working groups were in place and doing their best. Of course, that time, it's a question of trying to save lives. But all the different sector working groups, from rapid response team to the nutrition working group, treatment committee, were there. The current executive director, plus my better half, both of them public health physicians, were the technical working group assisting the commissioner then. And believe me, they did all they could to ensure that all the camps that were coming up like mushrooms had clinics and services being provided. And services within the communities also, intensified, both in the facilities and those working in the community itself through this community-based, control of common illnesses by people trained by different partners. So there was some coordination going on, and there was some activities going on before you could find people alive in Maiduguri by 2016. You people did not come until August 2016 when you stayed for 2 weeks. We had been in that crisis almost 4.5 years. All right? And things were going on. Now, I remember joining your group for almost 2 whole days before we were able to finalize that plan. Now, the person that drew up the Northeast Health Plan, which is called Buhari Plan, was my predecessor. Am I right? Dr. Anna Skolos, she was one that supervised the Northeast Plan, and she took her experience from Borno to come to the federal ministry as a director. She was the first director of special project, and she drew up that plan, which we now brought to Borno and again looked at the peculiarities of Borno and drew up the Borno Plan, which was implemented early 2017. So we're talking almost 5 years into the crisis. So a lot of the issues that are being talked about, we've been actually grappling with the problem since 2012. Okay? And the partners were there. There were coordination meetings at the state level where
the partners were there already.
They were already there. And at the state level, the secretary to the state government was chairing that group. And you have the health sector as a group, WASH as a group, food security as a group, protection as a group, education as a group, security as a group. They were all already meeting. And then in the health sector, they were having health sector meetings as well, but not regimented as we later on started in 2016. I'm just doing this to clarify, the situation. And believe me, the person that gave birth to the federal government-led intervention in 2017 was Dr. Alaki. Believe me, she made virtually a right act that the minister should call the governor and then all the other principal partners. And we were kept immediately. I remember it was supposed to be $30 million.
It was the 27th of June, 2016.
And we were virtually locked up in the room and said, okay, come up with a plan. Working group together with the other partners. And we came up with that plan. which later on was reduced. I remember the minister even saying, pray for me, I'm going to the ASROC the following week with a memo and the president was signed. You remember?
Yes.
But eventually, the federal government in her wisdom approved 4.3 billion, which I felt was also a colossal amount of money. And that was when, you know, the team came and we drew up a plan which was to last for 6 months. Okay? And they brought in quite a lot of commodities, logistics, and then we were able to engage teams of 25 teams of 14 each, covering all the different disciplines of medicine. And they were deployed to the local governments to work, and it made a very big difference, quite worrying. But to say there was no coordination initially before this team came was not true. There was coordination, there was serious work going on. And I explained, because he was one of the main actors working in the technical working group, supporting the commission at that time. Thank you very much.
All right. And now I will expect questions, real questions. And if there are no questions, that would be wonderful. No questions? Isn't that special? Okay, what comment?
Yeah, it was a great session. It was really great to hear Dr. Zodo talking about that incredible scale-up that was done at state level, and also wonderful to hear about the sort of various interventions. I loved what McLean said about the highlighting of women and girls, but I would very much like to go to the Honourable Commissioner's reference to the history. I think for us to know where we're going, we need always to remember where we have come from. And where we came from was a situation when I first went to Maiduguri, I don't know if you remember this, in 2015, where there was again, at a time where nobody was landing planes, I went in a private jet because there were no commercial airlines. To when we were at that meeting in June, as you said, I made a lot of noise and I got myself in all sorts of trouble. But we made a lot of noise and the presidency said, yes, sit together. But it was that sitting together, but from both federal and state level. I remember I met Dr. Azudu that day as we went to the ministry. It was that sitting together at those levels that enabled Nigeria's HRP, as we call it, from the international side, to increase. It doubled that day, from 200 and something million to 497, I believe. Until today, we now have a 1 billion HRP. But most importantly was the incredible Nigeria buy-in, which is what we're talking about here today. And the Nigeria buy-in, I think, is often underestimated as coming from the place where we were to the place where we got to on the day of, we call it Feed Borno, on the 27th of June 2016. And I think everybody, international partners, Nigerians, all of us really came together in a concerted effort that day and in that period to say that we need to save lives. And now we're coming together again, one floor down, maybe in the Hilton, but to say that, okay, we have done a lot of that immediate sort of life-saving work, but how do we now pull it all together? How do we have this humanitarian development peace nexus? How do we ensure that the gains of the past are built upon so that we strengthen our systems going forward? And so for me, really, just an exciting panel, an exciting conversation. Thank you very much.
And thank you very much. And anybody else? Number 3, number 4.
Excited to hear the history and also the plans for the future. My question directed to the pharmacist, Madam Sharif. I know pharmaceutical supplies and drugs, like you said, they are very, very important. The linchpin to health delivery is having those services and plus those commodities. What are the plans for the government in terms of a sustained, what you just mentioned about specific support from security, logistics and all that, supply chain? I just want to hear what the government is planning in terms of making sure that we have drugs at those locations you mentioned. There is storage, there is support to the partners who want to support and they face challenges in importation of drugs or even delivering drugs to the last mile. So that is something I'm interested to hear more about.
Okay, thank you.
I wish that a number of my international colleagues had been present for this very rich panel, because they're often in many of the capitals around the world are asking the question, so what has Nigeria done for itself in terms of facing up to this crisis? And by having a panel of actual practitioners who were there and who contributed, and thank you also for your contribution, I think that it makes it much more real and credible. So to turn this into a question, how is it that we can get the story out better about what Nigeria is doing for itself? Because we always like to help those who help themselves.
Okay. I review academic papers. I read a WHO paper. I reviewed it for a journal in which vaccination strategy was described. And I think it's novel, and I've never seen any paper like that. The authorship must be somebody in WHO Nigeria. Number 4.
Security project, wherein one of the components of the project is infrastructure and basic services, rehabilitation, reconstruction. I think the director mentioned about the building back better idea. Of course, it's not only a question of building back better the infrastructure per se, the software or the human resource that goes into the infrastructure, what plans one has, especially in enhancing the capacity of local resources, human capacity, while we need to build back better the infrastructure as well as the services. Thank you.
Okay.
Christian I just want to add to what, I don't know his name now, said, what has Nigeria done for itself? What are we doing about the localization agenda in humanitarian initiative? I'm aware there's a program ongoing now by ECHO. Are we really keen into it to ensure, because Dr. Dage was a welcome address was talking about, as I talked about, building Nigeria for even international humanitarian responses. So what are we doing on the localization program? Thanks.
Thank you very
much. Who just walked into the room. Thank you very much, sir, for being here. Honourable member of the House, and he's in charge of the humanitarian side of things within the House. So thank you very much.
Our humanitarian brother, you're welcome, honourable member.
Credibility in ensuring that I would say medicines and other health-related products are available all the time. What we have seen as a way forward from, like we said, development now is that more warehouses have been built. I'm sure, I'm aware that the Ministry of Health was responsible for building and upgrading a warehouse which is bigger to ensure that there are quality of medicines that are stored there. And then with the supply of the vans, delivery vans, so we provided delivery vans. That is because with quality standards, it's not just any van, the van that meets the needs to be able to take these items, to deliver these items to the community level that I'm aware of. And then the issue of, there's a supply chain management program which we have in the ministry, and in that management program has gone all over the states. And I know Borno happens to be one of the beneficiaries. They have set up their own coordinating unit in terms of that supply management. So I believe it's in place. I'm sure the commissioner will confirm that. But more importantly, to round up on all these issues, the way forward, one would suggest that the government must have a strong political will to continue, which I believe the government of Borno should continue. And it is expected at the end of this show, maybe within the next 2 or 3 years, I should look at Borno as having one of the best quality healthcare facilities because of these interventions, whether from donor agencies or from partners or from the Federal Ministry of Health. We should be seeing a better Borno with high level of qualified personnel, both locally and those internationally that have come, with improving facility structures in hospitals to deliver quality services, increase in number of such health facilities. One should be looking at going to Borno to benefit from those health facilities. Thank you.
Thank you. Thank you very much.
And I'm really quite thrilled that this is happening. I just want to further strengthen, deepen some of the discussion we've had by also indicating that what we have done in the last 2 years, by the way, the Federal Ministry of Health and the Borno State government declared a state of emergency on the 26th of July 2016. So that's the period that basically we've been addressing. We've also spoken to the issue that there were people in Borno State committed and working when there was no road, no airport, no visits, no partners, no this, no that. And that is a great resource that we must tap into. The Ministry of Health started the development of a strategic plan in 2013 and strengthened the Department of Special Projects to do that. The first director of Special Projects was Dr. Nasidi, so many years, like year 2000. So with his exit, there became a vacuum. And so when Dr. Kolo came back from her service, she continued what had been started. She didn't start it. And so the Ministry of Health, working with all the partners, did develop the strategic plan, and then we sent a team to the state and worked with the state. So we had a strategic plan, a plan with the state, an emergency response plan with the state, which was 19 billion. But of course, that was supposed to be a basket of funding. And so what the federal government identified as immediate, which must be provided by government, was 4.3 billion of that 19 billion. So if we actually look at what the partners have put since then, we may actually have almost made that 19 billion. But I think that going forward, therefore, it's important that we deepen coordination. Coordination is in existence. It's not perfect. But as we are going to build back, it's important that we strengthen coordination so that we can see all the resources that are available and have it appropriately channeled the way the state wants it. You see, international health is international, is foreign, is not on a concurrent list, unfortunately. And so there needs to be a strong federal presence to make sure that the state gets what it is supposed to get. Because it is international health, it's part of that component of the health sector that involves people, external partners. And so it's important that we strengthen coordination. We don't want situations where we have had in the past, even among us here, if you ask us to build facilities, and all of us come from the same local government, and we have access. Everybody wants the facility to be in their village. So if we all come from the same state, and there are 6 of us from one local government in the same state, it's likely that the 6 facilities will go to one local government because all 6 of us are from the same local government. And so that's the kind of thing that coordination will help us to ensure that whatever the state wants to do, the way it is going to support the health system to actually be better than it was. That's what should happen. It's also important to study what has happened in Borno State. A lot has happened. This commissioner you are seeing here and his team and the rest of us that have worked with them have a lot of resources that can actually work for not just Nigeria, but for Africa. Let me give you an example. When we went into Borno State, we had, our role was to support the state. The state was already, they had, like the commissioner has said, they were responding to things, and there was an emergency, so the immediate priority was to save lives. So they were willing to accept help from wherever it came from. So, but as things got better, you could now see the challenges of some of the help that were being received. Okay, and so the state was now in a better position to say, do this way, do this way, even reject some things. You know, some of them we stop them up front. And when the issue of the Emergency Operations Center came up, the commissioner was very passionate about it. You know, but it wasn't an option that flew with everybody at that time. So we made the team stronger, we made it bigger, and we worked within the resources that were available. And then we also started the mental health and psychosocial component of the program, which again brought in about 55 personnel into the team, drawing from people that had already been trained. And then there were linkages between the the State Ministry of Health, which was implementing the project, and the mental health, the Federal Neuropsychiatric Hospital in Maiduguri, and then the Department of Psychiatry in the Teaching Hospital in Maiduguri. So that was, like had already been said, the ministry also bought 4 trucks for drug distribution, 4 ambulances, and 4 pickups. That had been mentioned. So, and then we went, before the personnel were sent to the field, there were a series of training. We had training on, routine services they were going to provide. But we also looked at the issue of security for the people themselves. How do you manage personal security in the midst of crisis? We brought in people from the Department of State Services, the police, and all that to interface with the service providers. So there's a lot that is already on ground that we cannot tap into. So going forward, we are looking at how can we harness this into a process that can be replicated, can be studied and replicated.
Absolutely.
And also, how do we ensure that we have a framework that guides our response, so that we don't have a situation where a state says, and with evidence, that maybe the federal government was unfriendly, because nobody knew how to react. And so there's a need for us to now say, because there are states who can even make that statement today as we speak, like we have noted in the past. So there must be a framework that makes sure that one ABC the situation is reached in a humanitarian situation, the government must respond. Okay. Government must respond, and that government, everybody's responsibility must be clearly identified, so that if the Commissioner for Health of Borno State says, this has happened though, everybody gets going. You know what your role is. We also must be able, and I think my sister has gone out, I think that this is an interesting forum, but as a health sector, we need to deepen this process. It's not enough for us to sit here for 2 hours and talk, and then we go back. See, this is a 1-week process for the entire humanitarian system. As the health sector, we should take this further. We should call our people. We should look at how can we. Then the commissioner can be talking to his colleagues. The minister will be here and listening to what is being said. Other people, and then we can actually look at how do we fund it, because we are talking about sustainability and development and going forward. This is not enough, but it's a good starting point. And so we should be looking at, in the health sector, how can we harness the resources that we already have? How can the people that have been in the thick of this emergency talk to us? What are the lessons we can learn for the health sector? How do we say never again will this happen? What are the external determinants of the crisis that has led here, and how can the health sector influence it? Must we have a humanitarian emergency in our country? What are the things that we can do? How can we ensure that the security apparatus of this nation is looking at the health implications of their actions? So some of these things are things that we need to respond to, and we need to deal with them in a way that is more holistic. So we are saying, I'm suggesting, and I'm proposing that to this august body, that as a health sector, this process, we need to take it forward. We need to bring the other players, the people who make things happen, the people who are funding it. It's such an uphill task to get funding, even for humanitarian emergencies. It shouldn't be. It shouldn't be, because the people who are affected, some of them are people like us, whose lives were normal until something just happened, and they left everything that they represented just to save their lives and the lives of their families. One of the directors that was working with us in Borno State, the commissioner knows him, lost 2 of his children in the crisis. Not only did he lose them, the people that killed their children made a movie and sent to his phone. How do you manage that? How does a parent deal with that? And no, you see him, you are working with him, you are talking, and something can just happen and he snaps. So there are so many things that we need to talk about. So I want to really appreciate Dr. Alakija for this meeting, but also to say that this is just a tip of the iceberg. We need to take this further. We need to really talk about it, because an opportunity is a dialogue. We in the health sector should now talk to ourselves and talk to the people that make things happen for the health sector, who are not necessarily in the health sector. And there are a lot of people like that. Ministry of Finance, Ministry of Budget and National Planning, security institutions, people who take decisions that affect our lives every single day. And then we have no control over the outcome. Thank you very much.
Thank you very much. The last answer was so comprehensive, it addressed several other questions. It's perhaps you are advocating for a document that not only is in existence for application in conflict, humanitarian crisis situations, is available, and we know we've defined roles and responsibilities. We also have set a threshold at which it should be triggered. And I think it's not for the Northeast only. Crisis can come anywhere, God forbid, but it should be in existence. And whereas we have, I believe, any executive secretary, honorable commissioner, all that have acted in this theater can be huge resource, persons to developing this document. So I think one palpable outcome of this conversation, perhaps this is just the beginning. Perhaps I believe that Dr. Alakija and team will take it a little further so that we have something that is palpable. That document, that framework is available continuously and is ready for application anywhere in the country. It's not only going to tell our story, what we have done for ourselves, but also define what we can do for ourselves. It's going to clarify roles, it's going to provide some level of synergy so that people come into the theater and they know what roles they're expected to play. It is also going to define the question, it's going to be part of our localization agenda for humanitarianism, as the last person who asked the question. That document can also be the agenda for humanitarianism. And thank God we have structures, legislative structure for humanitarian activities. I want to thank each and every one of you. God bless you.